Welcome, everyone. So excited to convene again on a Sunday where we have our every other Sunday NBC webinar series where we dive into deep topics that are pertinent to the metastatic community. I'm so thrilled to be partnering with Abigail Johnson, who serves as our board of directors and co-spears our NBC leadership team initiatives. And I see a couple faces on this call also who are helping us shape the future of NBC for our survivingbreastcancer.org website. So I appreciate all of that. And thank you all in advance for submitting your questions. And I look forward to the discussion today. So thank you.
Thank you, Laura. So some of you may remember it was a couple of years ago now that Allison, who has since passed, we approached Laura to do a webinar / podcast series, talk about the things that nobody's talking about. And I think that we've done that. We've talked a whole lot about end of life issues. We've talked a whole lot about the things that are important to those of us in the NBC community. And it was, I don't know, like a week ago, 2 weeks ago, when Amanda and I were talking just about how everybody experiences progression in one way or another in the NBC community at one time or another. And why don't we talk about that a little bit more, since that is definitely top of mind. So that's how we got here today. So I invited Amy and Claudia to join Amanda and I to talk about this important topic. But I wanted to first start by, let's define progression. And then we'll get to some introductions. And so some people, when they've had an early stage diagnosis, and then when approximately 30% of those people then develop stage 4, some people call that a progression, right? You're going from an early stage progressing to a later stage diagnosis. So that's one way of progression. For those of us who are hormone positive, there's a whole lot more progression because you can't take away all of the estrogen in the body. So people who are hormone positive tend to have more progressions than, say, people who are triple negative, who tend to have discrete actual diagnoses. So, and Claudia will get into this a little bit when we turn it over to her to talk about her subtype. But one of the things I just wanted to start out with is this concept of progression is different for different subtypes. Progression is different for different stages. But in every case, what progression at its bottom line means is that the cancer has mutated. The cancer has figured out how to get around. And yes, I am anthropomorphizing cancer at this point, but cancer itself, because it mutates to get around the things that are killing it, it changes. And that is how progression occurs, when the cancer has changed, when the cancer has figured out how to get around medication. And so we talk about, we don't fail treatments, treatments fail us. But at the bottom line, progression is just how cancer grows and how cancer spreads and how cancer eventually, for those of us with NBC, will take over our bodies and kill us. And so that's why progression, I think, is such an important topic to cover, because it encompasses why we have scanxiety, why when we are tested or scanned every month or 3 months or 6 months or however often you're tested, we know what can happen. And so that's why I invited these amazing ladies to talk with us today about how they in particular handle progression and how progression has been a part of, or hasn't been a part of, their story. Because I think that it's important for people who have been on, say, one line of treatment, looking at you, Amy, and have been on that one line of treatment for years and years and years. How does that then change how they look at not only their cancer, but other people's cancer as well? So that I just wanted to give everybody an overview. That's what we're going to be talking about today. And now I'm going to get to some introductions. So Amy, since you are next to me in our little Brady Bunch thing here, would you like to introduce yourself?
Hi, so I am Amy Parliament. I am on my first line of treatment. My original diagnosis was stage 3C. I am a rarity. I had breast cancer in both breasts and a set of lymph nodes for my first diagnosis. I was hormone positive, ER and PR positive. And then 5 months to the day of my original diagnosis, I was diagnosed with METS. And I currently am an advocate. I also have a medical background. I do imaging. So I manage a department during the week, and then I go and still scan because I want to be able to interact with people that are getting scanned and stay current with questions and things that may come up in the community. And I look forward to sharing my story with you today. I was originally diagnosed in 2014. My metastatic diagnosis was in 2019. And I am still on my first line of treatment, which is Ibrance and Faslodex, for those of you who have questions. When I was early stage, I did 4 rounds of AC, and then I did 12 rounds of Taxol, 36 radiation treatments. And with my metastatic diagnosis, we just switched to the Ibrance and Faslodex, and then I had targeted radiation. If you're watching or watch this later, you can contact me on Facebook, or my email is grit74@gmail.com. My number is 845-754-5397. I'm available to answer questions that you or your family may have.
Thank you, Amy. And Amy is my go-to person to explain any kind of scans, because she can talk to you about how the scan happens, what's going on behind the scenes, what the doctor's looking for, what the limitations are of the scan. So thank you, Amy, for being so open with your contact information. One of Amy's passions is to help metastatic patients have a good relationship with their techs that are doing the scanning, because that relationship, that interaction can be really helpful, especially as we have questions or as we're trying to understand things. So thank you, Amy. Over to you, Claudia. Claudia is our representative with triple negative, and take it away, my friend.
Thank you, Abigail. I'm very happy to be here. My name is Claudia Gonzalez, and I was diagnosed in February of 2018 with triple negative metastatic breast cancer, metastasis to the bone. Went through the chemotherapy, then the mastectomy. And let me just clarify, it was on my right breast. And that was actually after I had a clear mammogram in January of 2018. I had a clear mammogram, supposedly clear, but I kept insisting until my OBG sent me to a breast surgeon. And that's when they did the biopsy and they discovered that it was a cancerous lump. And then again, February of 2018, did the chemotherapy, did the mastectomy of my right breast. Even though I wanted both breasts to be removed, they only removed my right, because supposedly there was a really a small chance of recurrence. So after that, I had radiation on my spine where the metastasis was found. Then I had radiation on my breast and my lymph nodes, in my lymph area. Then I started Celora. I was in Celora for I believe probably about 6 months or more, something like that. And then I was let free. Scans started coming, and get comfortable with the scan. I was getting comfortable with the scans because the scans were all no evidence, and continue going with my life. And then in 2021, June of 2021, I discovered a lump on my left breast. They did a biopsy, and again, it was triple negative also. Went through chemotherapy, and then they didn't do radiation. And then after that, my oncologist sent in my tumors for genomic testing. And it was found that I was PD-L1 positive. So that's when I started my immunotherapy with Keytruda, which I've been having that since February I've been having every 3 weeks Keturah treatment since February. And I'm on my 13th Keturah right now.
I was asking Claudia this weekend how many she had, so thank you for counting them up.
I know, yeah.
It's hard to remember sometimes
Yes,
when
it
we're in the
is.
midst of things. Yeah. So I wanted to point out that Claudia used the word reoccurrence. And so for people who are triple negative, even though they will always be stage 4, because once you are stage 4, there's no going backwards. But this reoccurrence was just a stage 3 reoccurrence, right, Claudia?
Correct.
Okay.
Yes. Mm-hmm.
And that while it seems weird, that is normal for triple negative. So if they have a good response to chemo, there are often no evidence of disease for months, years. I think Janice has been dancing with no evidence of disease now for 6 years,
Yes.
or maybe it's 5, somewhere in there. I think I try to keep promoting her, even though maybe she hasn't quite reached that.
Yes.
But for people with triple negative, it's normal when there is a reoccurrence not to be restaged technically, even though sometimes some doctors will say you have both stage 4 and a stage 3 diagnosis. So little confusing at times,
Yes.
right?
Mm-hmm.
Especially for those of us in the hormone positive world where, you know, we stay on treatment forever, and unless we take a holiday or something like that. A lot of times triple negative patients are able to be off medication for years, even though there's still a fair amount of surveillance. So how often were you getting scans when you were no evidence of disease, Claudia?
I was getting scans every 4 to 5 months. And when I walked into my oncologist's office right after my mammogram that same day, she was ready to let me know that my scans were going to be every 6 months. And then I told her, haven't you heard what just happened? And she went and found out. And I told her what had happened, and she went to the next door and said, I'm gonna find you a surgeon right now, and they're gonna do the biopsy right now. So that's how it happened. So right now I'm on every 3 months scans.
Okay.
Mm-hmm.
So Claudia also referenced a somatic mutation. So some of you may realize there's a difference between germline and somatic mutations. Amanda will probably talk a little bit about the germline mutation she and I share that came from, it's in our DNA, came from our parents. A somatic mutation is a mutation that the cancer itself has acquired. And the PD-L1 somatic mutation is also one that indicates that the cancer is sensitive to chemotherapy. I'm sorry, to immunotherapy, not chemotherapy, immunotherapy. And Keytruda is one of those immunotherapy medications. So basically it is teaching the immune system what to do and revving up the immune system to have it do the thing that it is supposed to do, which is kill the cancer. But as we know, once we've been diagnosed with cancer, that means our bodies have not been able to, they haven't been able to stop the cancer, right? The immune system isn't able to stop it. And so immunotherapy, the goal of immunotherapy is not only to rev up your immune system, but also to teach your immune system what to look at. So this theory, the hope for Claudia and for other people who have PD-L1 is that eventually they'll be able to go off of the immunotherapy and the immune system takes over, right? Cross your fingers. That is legitimately, I think, the future of precision medicine is teaching our immune systems what to do. All right, Claudia, anything else you want to say in your introduction?
No, I think that's it. Pretty much.
Okay. All right, we'll come back to your question.
Yeah, yes.
Great. Thank you, Claudia. All right, Amanda, over to you. You do not need to list all of the medications you've been on unless you really want to.
Probably couldn't list them if I tried. I have to write them down to remember them all. But hi, everybody. My name is Amanda Raffinad, and I'm happy to be here. Thank you, Abigail and Laura. I know this isn't our first time together. I just really appreciate this outlet and what you guys are doing for so many people. It's so necessary. I've been living with metastatic breast cancer for 3.5 years. It'll be 4 years in December. So I was diagnosed December 2018, stage 4 de novo, did not have an earlier stage diagnosis. And as Abigail alluded to, right around the time I was getting diagnosed, we were also doing genetic testing and found that I have the ATM mutation. And so this is a germline mutation, something that I inherited from my mother. She also had a breast cancer diagnosis, but was early stage. And she's not had, once she had her mastectomy, she was stage 0. So she did not need treatment necessarily beyond that. So I also, like Claudia, had kind of an unfortunate diagnoses situation where I was under their surveillance of a breast care surgeon for about 4 years. Just given our family history, both my grandmothers had breast cancer, and all of my mammograms were clear, ultrasounds clear. And it was one day I was walking from work to my car having trouble literally moving my legs. And I thought, what is going on? And so it was time for like annual MRI. And at that point, it identified multiple spots of malignancy in the breast that was missed on the mammogram ultrasound. And it had already spread to my sternum and some other bones that it picked up on the MRI. So just a very shocking diagnosis. And, going from my mom's experience with stage 0, which seemed like such a short kind of, she didn't have chemo, she didn't have radiation, to now it's here at stage 4, it's on my bones. It was a lot to wrap my mind around. And I got about 2 years out of my first line of treatment. I was also hormone positive, ER/PR positive. So I was on Ibrance and letrozole. So I almost got 2 years out of treatment, which was great. And then it seems like at that point, my body just decided it did not want to respond to anything. And so I'm now on my 8th line of treatment. I have multiple subtypes. I also have triple negative. We found through my biopsy, I think it was in summer of 2021. I've had multiple biopsies. And so unfortunately, it seems like every 2 to 3 months when I go for a scan, there is another area of progression. And it has been mind-numbing, to be honest, because it seems like, like Abigail said, the cancer is trying to do what it can do to not respond to this treatment. And so it's been a lot of trauma, because you hear of people that live, for many, many years on their first line and then get, maybe a year on their second line. And so I'm at the point where I've gone through all the hormonal therapies. I'm resistant to those. I'm pretty sure I'm resistant to all chemotherapy, but we just keep trying. There's a couple more options that we have, but I've had multiple rounds of radiation. I'm currently in radiation right now, again, for my spine, my thoracic spine, but it's everything has spread from 2018. I was just bone only to now it's in my lungs, and I have pleural effusions. It's really all over my liver. I think my last scan that they actually counted just stopped counting at 15 tumors and said, we're going to give you a 15 plus because, we'll identify the big ones and that's it. And then it spread to my brain in June, so a couple of months ago. And that was, of course, shocking. And that is just another, really hard piece of news to wrap your mind around. I had gamma knife radiation in July. And so I just had my follow-up brain scan. I don't know the results yet, but we'll see what happened with the gamma knife. And it's just, I feel like my doctor calls it whack-a-mole at this point. Every 2 to 3 months we're scanning and we're figuring out what the priority area is. And Obviously, we want a systemic treatment to be effective. And I don't know if I'm going to get that. And that's the reality, that there are many people living with this disease and treatments just keep failing. And I would never have guessed that getting almost 2 years out of Ibrance, I'd be where I am today with, turning over treatments every 3 months. But here I am. And, what do? You try to find life in it, just like you do if you're still on your first line. So it's definitely been a roller coaster. I'm trying to think if there's anything else of other than the germline mutation, the ATN mutation. I've had many somatic mutations, and some come in and some fall off. Cancer is the weirdest thing. I've been on a clinical trial. I've been on standard IV chemotherapy. I've been on oral chemotherapy. I've tried so many different options. Right now I'm on Doxil chemotherapy, and then looking at maybe a trial in the future if I have a stable brain scan. So still not giving up, even though I know these treatments, for some they work and for some they don't. And so anything else I should add after that?
No, I think you're good. You'll have a chance to weigh in on some of the other questions. Thank you, Amanda. So I just want to stop and acknowledge that for those of us who are in the community and have the same diagnosis, that seeing somebody like Amanda, who is just blowing through treatments every 3 months, it can be really scary. It can be really traumatizing to see somebody else who is having a much more difficult time versus getting time on the treatment. So if you're feeling a little uncomfortable after Amanda just shared about her experience or experiences and how they're going, that is incredibly normal, because in some ways, Amanda's experience is our future when the cancer begins to get out of control and the medication can't control it. So that's part of the reason why I wanted Amanda to come and talk to everybody today, because how she's dealing with that, I think, is very instructive for everybody. So we'll circle back to you, Amanda. Amy, I wanted to have you talk a little bit about somebody asked a question about listening to your body, and when your intuition conflicts with maybe the tests and the doctor can't confirm that your intuition is correct, but then later can confirm that you were right. And Amy had a bit of an experience with that. So Amy, would you like to share with everybody your experiences with that?
Yes, so I found my cancer the first time as well. For 2 years, I went back and forth to the doctor, and I'm like, something doesn't feel right in my breast. And they're like, no, it's nothing, it's your imagination, it's a ligament. And so it ended up being, my original cancer was in the fold. Well, I don't stand in front of the mirror and dance and look at myself, so I didn't see it. So by the time I found my first cancer, it had grown to the skin. So I had the dimpling. With my medical knowledge, I felt embarrassed that I didn't know sooner, but I was going and nothing was showing it because I have dense breast, never had any children. There's no history of cancer in my family except a grandmother, and they don't even know what type of cancer because they didn't ask years ago what it was. So found the first cancer and then had to advocate for myself and push because I was 39. I was 39, and they're like, you're too young, you don't have it. And I'm like, yes. And so every step of the way was an argument. I do medical imaging. I am an MRI technologist first and foremost before managing. So I often was the test that told the lady what line of treatment she was going to get, and swore from day one, if I ever got diagnosed, I was walking in, we were cutting both of them off and moving forward, because I just watched progression and watched other things. So then I had my first diagnosis, getting to my 5-year mark, getting ready to get off of the hormone therapy, and had just come to terms with getting my port out. I kept my port for 5 years because I kept feeling like I'm going to have something that comes back. So I didn't want to give up my port. When they would talk about removing it, I would have a meltdown sitting every month when they would like, you can get rid of it, you can get rid of it. And on the 5th, right before my 5-year mark, I felt a pain. I was standing and I felt the pain in my back, and I'm like, whoa, this is weird. I have scoliosis. I had brain surgery, so I'm very familiar with the medical community on the other side. So I went back to the oncologist and I'm like, something's not right. And she drew some blood work and my cancer markers were a little elevated. When I say a little elevated, I mean like 0.10. And I'm like, no, something's going on inside my body. I think we need to do a scan. So I had just graduated to 6 months and we were going to move to the year mark because here I am at 5 years. And I'm like, can we just do a scan? Did a scan and there it was, the mass in the back. So here we go with all the testing. And a lot of people ask, they're like, you don't press for a PET CT? I have lobular cancer. Mine metastasized to my bone first. So for me, a CAT scan and a bone scan was the better test for my type of cancer, the type of hormones. But I was a rarity. I too was like these other people on the call that my cancer changed properties. So I went from ER/PR positive to now I'm slightly ER positive. So I am still on my first line of treatment. I'm 43 cycles in, but I need you to know every month when I go to get blood work, I hold my breath until I see my tumor markers, because with every ache and pain, you wonder. I've been getting Faslodex shots, 43 of those in my buttocks, so that it's sitting on the nerve. So when I have leg pain, I don't know, is it from the shots? Is it cancer? Is it something else? And I still image women, so I know that stuff happens. People listen to their body. So the one thing I can tell you, if you have an ache or a pain, you got to tell your doctor. You can't hide that. And that's how each time I found my cancer prior to medical imaging, we've either done a test a few months before that didn't pick it up. So in a matter of 3 to 6 months, it's grown, it's done something. So literally, you have to know your body. You'll know if the medicine's working, not working. I think that that's my biggest thing, that one of the reasons I have stayed working is because for as long as I can, I want to be a voice out there on the front lines for women to realize you gotta talk to your doctor. You gotta be educated. You don't have to know all the medical terms, but you know if you feel something or you know something, and if you don't get the answer you want, you keep going. You go to a different doctor, you go somewhere else until somebody listens.
Thank you for that, Amy. I think that sometimes there are those people in the medical profession who I think have good intentions and they try to downplay perhaps people's fears. And it's such a balance, right, between being concerned enough to speak up or allowing some of that negativity, because that we all have it, right? Once that diagnosis has come, the worst possible thing has already happened. And so you're always waiting for the second shoe to drop. And so there can be some amount of you feel something and you never think it's a normal human problem, like a pulled muscle. You always go immediately to it's got to be the cancer. So there has to be a balance there. But speaking up and saying to the doctor, no, something is wrong. You need to keep looking is important. But Amy, since you have been on your first line of treatment for those 43 amazing cycles, how does it affect you when you see other people experiencing similar to Amanda, where they have progression after progression? How does that affect you?
So I'm going to be honest on this call. I did not get any scans for 15 months because my friends were getting scanned, and Abigail knows this. My friends were getting scanned and they had progression after progression after progression. I do those scans. So I know when I get up and I'm going to be scanned by somebody I know, I'm reading their face and they're trying not to have a reaction the same way I do when we do a patient. When I'm laying there, if I'm laying there an extra 30 seconds, I know they're looking for something. I know if they do a certain thing, they're looking. I know the noises. So it's kind of traumatic. It's very scary. And that's the thing. I've talked to my oncologist about it. Like, they threatened to take away the treatment I was on because I was afraid to get scanned. And she's like, why are you not going? And I'm like, everybody I know, they're either dying or they're having progression. It's inevitable. I know I will have progression. And my fear is when I have my progression, because I am lobular, mine will be every 3 months I've got to change a treatment or whatever. And so I have to try to do something positive to put myself somewhere else to not stay in my head. And sometimes it's easy and other days it's horrible, because there are days that when I go in to scan, every single patient I scan, when they get to their doctor the next time, they're going to be told either they're metastatic or that they've had progression. Actually, today I took care of a patient that thinks that they're in the clear, and I had to act like that they're in the clear, but when they get the call this week, it's not going to be good. So it was a hard ride home today, because I'm like, I know at some point that's going to be that's going to be me. Like I know it's going to happen. It's just, when will it happen? And I'm past the mark on Ibrance, so I feel lucky. So when you hear somebody else, I've heard people say 8 years or 10 years, like you're excited, but there's also a sense of guilt too, because I'm like, why does it work for me and it don't work for the other person? Like you wonder that, like, what is it about me that it works and it doesn't work? And you, not that you want to be rapidly changing, but you think all these thoughts. It's a difficult position to be in, because you kind of feel like you feel bad or feel a little guilty, that, you know what I mean? But you shouldn't feel that way either.
Thank you for sharing that. And thank you for sharing that you were avoiding your scans, because I think that is something that probably other people do as well.
Don't do it.
Whether-
Listen to me. Don't do it. Don't do. I mean, I know that's the pot calling the kettle black. Don't do it. It's not worth it. Like, I have scans scheduled again. Like, we made sure since I got through the last one, they're scheduled again in a timely manner, but I couldn't go there. I was watching with the numbers, and look, I was in a group with several of these ladies, and they would talk about getting scanned, and I never just said, I'm like, at some point they're going to ask me, when are your scans? Because I never said I've got scans. I just avoided the topic. But don't do it. And if you're afraid, call me. I'll tell you how to get through it.
And let's not forget that there are medications that will help with getting through anxiety. Are you taking anything, Amy, to help you?
Yeah, I do. I have to. Listen, I perform these scans, but I cry with the best of them. I have to be held down on the table. Somebody stands in the room. So when I tell you I know it can happen, I know it can happen. I perform them, and I'm a terrible patient when it comes to that, not being the other, but when it comes to being scanned, I think it's the 22 years in the field and the knowledge that it makes me even more so afraid, because I know if it's something is out of the normal, I know before I'm going to the doctor that I'm there. So
one of the secondary questions in that question about whether the doctor is listening to you or not, trusting your intuition, is how do you trust the doctor when the doctor is saying, oh, it's no big deal, and then you find out it actually is? Does that change your trust, Amy, in the medical profession or in your doctor?
it does. And this is what I tell people. In the medical field, we go with science. So they go with what the numbers say and what the studies say. And I think as time goes on, they start to listen to the patient a little more. But even in my field, when somebody comes in and they're like, I got something and I know something, you're like, no, because you'd be this way or not. But you know what? Time and again, I've seen over the years where a patient really does know if something's going on or not going on. And then oftentimes we get patients that they are far progressed. And years ago, I'd be like, how could they not know? But now I realize it's denial. You're like, if you don't acknowledge it and you don't know it's there, then it doesn't exist. And then sometimes I think people could have had a better shot if they would have just gone and not been afraid. So as people that live with the disease, if we have to share so that way maybe we can save somebody else from being so far progressed. Or everybody's body is different. Like maybe my cancer grows slower, Amanda's grows a little faster. There's no like right or wrong reason or no rhyme. I often know too, and Abigail, you know this from other things that we've done, some people don't believe that the blood work can show if you've got progression, while other people know that that's how they've known when they've had progression. There's so many arguments. So I think that we have to remember, while it's all the same disease, we're all individual. We're just snowflakes. And so we have to all adjust and know what makes each of us comfortable.
So very key and important. Amy also mentioned that she had gotten more time on Ibrance than what the studies show. And so the studies will give a a progression-free survival interval or an overall survival interval. And that's based on statistics. That's based on, the average patient. And so while there are people who get that 24, 26 months on Ibrance, which is what the study says, and then there are people who get years and years and years on Ibrance. So such an important reminder that we're also different. The other thing that Amy mentioned was blood work, and I think she's specifically talking about tumor markers. Some doctors believe in tumor markers, some doctors don't even pull tumor markers, but some people's tumor markers are spot on. And it's important that if your tumor markers, and all tumor markers they're testing different proteins that show up in the blood. And there are different ones, right? There's the CEA, there's CA 15-13, there's 27, 29, probably more. Those are the three that I've had over the years, but they test different proteins that can be affected by different supplements that you're taking. And so just as a reminder to make sure that if you're doing any kind of supplements, the what I know for sure, biotin will sometimes artificially raise tumor markers. It depends on your body. So some people, you know exactly what's happening when those markers start to rise. Some people, it's completely the opposite. And so knowing your body, knowing the trends, which a trend is 3 data points. I keep having to remind myself of this. 1 raise in tumor markers, that's not enough to really be concerned. It's when you have at least 3 data points that there's a trend upwards or down, or mine recently have been doing some funky mountaintop weirdness. So Amanda, you've got your hand raised. Did you want to weigh in?
Yes, I wanted to add to something that Amy was saying, and I think that you were getting to also, Abigail, is just the extreme individuality that this disease has. And I remember meeting Abigail. We had the exact same germline mutation, very similar diagnosis story, both bone only, and I went this way and then she went this way. And so even with similarities in the beginning, I mean, everybody is so unique. And now even looking at testing for things like PD-L1, immunotherapy markers, things like that, Abigail and I have very different results. And so I think as you're hearing different people's stories, and, Amy, who's on her first line, and here I am on my 8th line in 3.5 years, just remember that everybody's so unique. And I often tell a friend of mine with advanced cancer, she's a different kind, but my story is not her story. And I think that's important to remember, that we all are living our own individual stories, including how this cancer is going to grow and manifest. And, just like we celebrate Janet's 5 or 6 years dancing with Ned, I mean, there are those amazing stories. And so I don't know what's going to happen in my case either. Even though we keep going down the line, it's like we still hold the hope that this, even though the history might want to tell us differently, but we hold hope that, something is going to actually catch it and I'll have a period of being stable. And so as you're hearing these just different experiences, remember, my experience is not necessarily going to be your experience, at least in the timeline that I've experienced progression. So I just wanted to add that because I know it can be scary.
Yeah, and then
thank you.
6 months ago, my oncologist came to, was it 6 months ago, Abigail? 3 to 6 months ago.
Mm-hmm.
About 6 months ago, because my oncologist knows I'm doing nothing without research, calling all my people, getting everybody's opinion. They came to me because I have lobular. So the thought is, when I progress, it won't be bones next time. It will be organs and possibly brain, just because the type of cancer, like a lot of details. So they came to me and let's get ahead of it and let's just switch treatment. I literally was freaking out, calling Abigail, reading, trying to do some other stuff. And I'm like, oh, I don't want to mess with anything. I don't want to change anything. I don't know what to do. So they let me sit on it. So I have remained on Ibrance. But to my oncologist's point, that's risky because the next thing she wants to try me on would stop the crossover to the brain. But I don't want to change anything because right now this is working. So it's, do you make the decision to try to get ahead of it, or do you stay where you're at? What I can tell you is you take the knowledge of the stories that you hear and you do what is best and right for you. as the individual, because there is no right or wrong answer. It's what works best for you.
Yes, absolutely. The doctors have the statistics, right? They know the average experiences, or they know the statistical likelihood of various subtypes, like invasive lobular carcinoma does tend to go to the brain, whereas invasive ductal carcinoma tends to go to the bones first. So in some ways, Amy's cancer is, or the cancer in Amy's body, it's not hers, it's just in her body. It is already behaving oddly. And that's just a good example of, we have statistics, we have likelihoods, but then we still are individuals and we have to make those decisions about our individual situation. Thank you, Amy, for pointing that out. Amanda, I just wanted to ask you, I asked Amy about how she experiences other people going through progression as somebody who hasn't had progression. How is it for you when you see people dancing with Ned or going through progression? How does that affect you based on the fact that you've had so much progression?
Yeah, I think when I hear of somebody having progression, I just have deep compassion, because I know what that's like to get those results, and to, it's almost like back to square one, where you're getting that diagnosis all over again, because you have to regroup and you've got to figure out, okay, what's the next best treatment line? And there's so much that goes into it. So I just have deep, deep compassion, and I know what, you know, I've experienced similar feelings. When I hear people dancing with Ned, I get so excited, because I feel like we have still so much to learn in the medical community, the scientific community around research and what is driving cancer. And I mean, we are just scratching the surface of what we know. And so for something to work for somebody means that there's a win, and that is a beautiful thing. That is a necessary thing. And so I get excited for that. And then at the same time, I think, okay, what do we not know about what's happening in my body? Because there's still too much unknown, and that's why we are where we are. And so I tend to get really curious, but I celebrate with those who celebrate, and then, you know, mourn with those who mourn. I feel like that's kind of where I'm at.
So I wanted Amanda to say that. I didn't prepare her for that, but I figured that's what she was going to say, because I have heard some people who have not had a lot of progressions say that they're reticent to share their good news. They're reticent to celebrate because there are so many other people who are not. And so I wanted you to hear it from Amanda, who has had a lot of struggle with progression, that sharing your good news is good news for everybody. When we see other people doing well, we know that that's good information for the scientists. That's good information for somebody to look at. Why is this drug working for this person and not somebody else? So just wanted to say that. Claudia, talk about how you experience other people's progressions or other people's good news, especially when you're in that, you know, when nothing was going on and you were no evidence of disease.
Yes, I think that one of the good things about having the community out there of every, you know, people who have metastatic breast cancer, it kind of goes both ways. When I was first diagnosed and I found out that Janice had exactly the same thing as me and that she was free for so long, I'm like, yes, that's gonna be me. That's definitely gonna be me. Yes. And then when I found out that the cancer had come back on my left breast, I was like, what happened? Why can my life, you know, why can I not be like that? What did happen? What was going on? Why didn't I, was it something that I wasn't aware of? Was it something that I didn't read? Was it something that my oncologist did not tell me? And so, yes, you start thinking about all those things. When you have other people that I've known through the metastatic breast cancer community, like you, Abigail, that I've known you for so long, and that I seen pictures of you when you were really sick. I seen pictures of you when you were, like with no cancer, with cancer, with treatment not working, with treatment working. You just want to do something. You want to do something for that person, and not only for that person, but you want to do something for others. I want to learn more about triple negative, or I want to learn more about stage 4, and see how I can help, just like I got helped through the process. Because it was actually when I found out about my second diagnosis, the second time I emailed Christina, and she was the one who told me, ask your doctor about the genomic testing, and Janice was the same way. Ask her about the genomic test. So yes. So yes, again, the community gives you both things. It gives you the knowledge, and it also gives me, it has given me the blessing to meet people who are going through different things, who are in different medications than I am, who I can support, who, when I feel down or if I have a question, I can ask someone. So that's basically what it has been for me.
So there's that double-edged sword to a certain
Yes,
extent, right? You
absolutely.
see the good and the bad.
The good and the bad.
Being in community with other people with the same diagnosis. But I want to ask each of you, and I'll go back to Amy, even amongst all of the, sorry, there was a cat fight at my house. Our nanny has a cat, and we have a cat, and they still haven't figured out who is the supreme leader of the household. So Amy, I wanted to go back to you. As you experience the negatives of your own diagnosis, or the negatives in the community of seeing people struggle, or even as we attend funerals, seeing others die, what makes you keep wanting to engage with the MBC community?
Because I feel like that is the only community that gets how I feel. Like, I feel like they understand, even if I've had minimal progression, if I have a fear or have anxiety about something, if I share, I feel like they understand how I feel. We might not feel the exact same way, but I also feel like genuinely, and for the most part, we understand like what 5 minutes of somebody's time means, or what it is, that like you might not get a second chance to have that conversation or to say something. You know what I mean? I struggle with going to sleep at night because it's like, oh, every night, like, am I gonna have this ache or pain? Is it gonna be something? Because like, did I leave anything on the table? And I think for the community, I have made some great friendships. I have made great connections. And I feel like even in the worst of times, there's some kind of joyous thing. And in the best of times, there's also some sadness because there's people we're missing or whatever. So it's like a balance, and it forces you to like look at life. For me, scanning patients is becoming more difficult because when I see it, like I would see the same patients over and over, but now when they don't come back, I'm like, oh, are they still here? Because it's not like I can go and look. You know what I mean? I don't know I'm outside of that circumstances, but you want to know. But you also know, because I've seen friends like lose friends over the last few years, that I also know how hard it is on the friends and the family. And I think for me, what I've realized is sometimes my family gets jealous of the friendships, because if I'm going through something, the first thing I want to do is come to my community that's going to give me the tools I need to go to my family, versus I don't want my family to understand the fears I have or whatever, because I don't want them to ever have to experience it from this perspective. You know what I mean? They give care, but none of us in this group probably would want our family to feel or know exactly how we think about things, because that means that they're living the same kind of journey. So for me, I think that's why I continue to do it. And I want the next person, there's going to be somebody after us. I don't want them to feel alone or isolated. I want them to feel supported. So if we spread the word, then the tools are there for those people that are going to come after us.
Absolutely. Thank you. Thank you for that, Amy. And Amanda, I want to come over to you because you have one adult son, one almost adult son. And Amy just talked about the, burdening the family and how the family looks at our struggles or our experiences. What is it like with your kiddos as you're going through progression after progression?
Yeah. I mean, it's so tough. And I think there are times where I don't even want to talk about it with them. Talking about it with the NBC community is different. Again, like Amy said, it's a community that gets it. They're living it too. They're walking it too. But it's just been traumatic. And I'm also a single parent. And so to inflict that trauma on my boys over and over is not anything I want to do ever. And so, it's hard. And so we actually talk often about what they want to know. And if they don't want to know the details, that's okay. And we, strategize about what our conversations can look like around treatment. And do they want to know when I have scans? They want to know when I have, a treatment change. And so far they do. They've stayed in the know. And, we have great support. We have counselors and mentors and family and all of that that's just around us. But I do feel like it's not a one-way through. There's a lot of reassessing, what's the right conversation to have, and being mindful of if the news is something that they can even process in the moment. As students, my oldest son transferred from North Carolina to a university here in Florida. And so that was a big transition. And it's like, that's his focus, not cancer, not my diagnosis. And so not this diagnosis. So it's a moving target, but they've been amazing. They've been amazing.
And I wonder, so I'm going to flip over to Claudia in a moment because she has daughters. Amanda has two sons. How is it different, do you think? And then I'll ask Amanda, or I'm sorry, ask Claudia. But how is it different, do you think, because you have boys and the likelihood of them getting breast cancer, even with ATM, is still low? How do you think that changes your conversations with them, or does it?
Yes, I think, initially they think, they're okay, they're men, so they're not going to get it. And so we've had conversations around, okay, well, men can still get it, even though it's a lot. It's not as common. My oldest actually did test for the ATM mutation and does not have it. And so that was a really big moment of just, does he want to do it? And that was his choice to test. And then, kind of holding your breath, and then doesn't have it, and being so grateful for that, because the ATM mutation causes increased risk of other cancers as well. And so it's tough. It's tough because I think when I was 38 when I was diagnosed, and when you look at just the incidence of cancer, it seems like it's just on the rise in general. And so our minds have been open, not just about breast cancer, but so many different kinds. And, what can we do? What are we powerless, even if we try to do something, and in terms of prevention? And I don't even know where I land on some of that stuff anymore because of just my own experience. But just a lot of conversation.
Good. Thank you, Amanda.
Yeah.
One thing that has always frustrated me as a parent is that germline mutations that might raise the incidence of breast cancer or any other type of cancer, you can't test your children. They get to make that decision when they turn 18. And so, not knowing, right? Being in that situation of not knowing, I think the general knowledge or general thought in the medical community is that we want people to be able to make their own decisions and not to have something hanging over them. But still, as a parent, still kind of want to know. So Claudia, talk to us about how does it change, or how does your experience maybe different from Amanda's, having girls versus boys, and talking to them about progression or how things are going?
Well, that was my first fear. Right after diagnosis, my first fear was, okay, are my daughters gonna get this too? I have three daughters. My oldest is 33, my youngest is 22, and then my middle one is 30. So yes, that was definitely my first fear. What is going to happen to them? Unfortunately, fortunately, I didn't test any, all my BRCAs were negative. I didn't have anything like that, but it still is in the back of my mind. What is, where did my cancer came from, and where is it going to go to my daughter? So we had that conversation. I had that conversation with the three of them, and yeah, they can't get a mammogram yet because probably they're too young for that. I've been pushing my oldest to ask, and she has asked her gynecologist. Okay, I want to know more. I want to start getting mammograms. So that's definitely important. I don't know if it's along the same lines or not, but I just wanted to also talk about family reactions. And in my case, I come from a very, very strong Catholic background. And when I say to my family, when my family found out I have cancer, everybody is like, don't worry about it. You're going to be fine. And is that kind of mentality that is not going to happen to you, you're going to be fine. And trusting God that you're not going to, that is going to be nothing. And that's frustrating at times that they think that way. Because yes, my faith is, I have a really strong faith, but at the same time, our bodies matter. So our bodies react differently because of different circumstances. And when I got my second diagnosis, there was one time that my mom said something that really bugged me, really bothered me, because yes, why did you get it again if your faith is so strong? But that's not the way it is. That's not the way it is. Again, it's our bodies that respond to whatever is in us. Yes, the faith has kept me through, given me a strength to go through all these things. But I do feel that in a lot of the times, my family kind of negates what is really happening to me. And that's hard.
Yeah. Amanda and I have had these conversations quite a bit about how people in the religious community often look at things like an illness in a very negative way. I mean, I was literally asked by more than one person, what sin did I have unconfessed in my life that would have caused this thing to happen? And I have a feeling Amy wanted to weigh in on that as well.
You have no
She comes from a faith background also.
Yeah, so I come from a faith background, and I'm very, like, I live and walk by faith, but I feel like it's a one-person journey, right? Like it can't be my parents can't do it for me. But when I got diagnosed, when I thought I had cancer and I told my family I think it's cancer, they're like, no, it's just an infection. I'm like, no, like before I ever got diagnosed, I'm like 99% sure something's not right. So I get diagnosed. And just so you guys are aware, I thought I was stage 1. The surgeon said I was stage 1. Nothing showed up on the initial imaging except like that I had one small mass and I had cancer in both breast and lymph nodes. So when I went into surgery, I thought having a bilateral mastectomy, I did not think I needed chemo, radiation, nothing. We thought I was one and done. And when I woke up, I had had nerve blocks because they found the cancer in the lymph nodes during surgery. And so I woke up screaming, asking for my mom because I wanted to see her face to know if it was somewhere else. So my family, we're going to pray it away. We're going to pray it away. And which I appreciate, pray for me, but don't just pray for me. Know I'm human. And even though I have faith, I'm going to be doubtful too in some of these circumstances. So the second time when it came back, they're like, nope, it's not cancer. I'm like, but I'm pretty sure it is. And I got the same questions, Claudia. What did you do? Like, why are you getting it again? And like, God gave it to you? No, like, that's not the thing. Like, if I want to live by faith, then I've got to be an example to you that I can't go to pieces. It doesn't mean I can't have a bad day and be negative. It just means that I got to trust in the process and that it's going to work. You know what I mean? At some point, it's going to work. This is like, I know, Abigail, you hate the word journey. It's my journey, not your journey or somebody else's. This is my path to walk. So am I supposed to be an example for somebody else on how they proceed? Okay, I can be a better human and I can't get angry. That's where my faith comes into place. It's happening. Like, I'm part of this and it happens to me, but it doesn't mean that just because it's happening to me, I got to be miserable to everybody else. And I think that's where people that don't have faith or do have faith go the other way. But that's probably been the hardest thing because they're waiting to see, are you going to say something? Are you going to be crazy? But I'm a human first. And that's what I think people forget. They think just because you have faith, you can't have fear. And you can have fear.
Yeah,
for sure.
One of the books that I have loved as part of, you know, understanding this experience, and journey is still something that's like, you go on a journey by choice. I'm like, this is not a choice that I've made to be in this experience. So that's why I don't like the word journey, but I am fine with other people using it. But one of the authors that I have loved, and I know Amanda follows her as well, is Kate Bowler, who wrote the book Everything Happens for a Reason and Other Lies I've Loved. And she has stage 4 colorectal cancer and is a professor at not Duke. She's a professor somewhere. Is it Duke? Oh, okay. Anyway, so but the idea that because the prosperity gospel is what her dissertation was on, and this idea that if you if you love God and if you're in the right path, then everything will be wonderful for you. You will have prosperity. And just that how that then becomes something of a patient shaming situation. And Claudia talked a little bit earlier about, you know, what should I have done? What should I have done differently? What should I not have done? I think these questions come up all the time, but at the end of the day, we are helpless. And I think that is one of the lessons that I've learned through this process, is that we are helpless to ourselves. Ourselves are going to do what they are going to do. We can do every single thing right, and our cells are still going to do something. Our immune systems are still not going to work properly, or you know, those tumor markers are going to go up and down or whatever, but we don't have control over those things. And as somebody who's very high on the control scale, like, you know, off the charts, that has been a very difficult thing for me to accept, that there is not really anything that I can do to change the trajectory of the cells in my body. I can influence how I feel about those things. I can work on being mindful. I can work on being grateful. I read something somewhere that whatever you're filling up your mind, your spirit, your experience with, that's what comes out. So if you're angry about the situation, anger is going to come out. If you are focusing really hard on being grateful, then a lot of times gratitude can come out. Although I still think that sometimes anger is very healthy. It's healthy to feel our emotions about the situation. We are getting here to 5, but I did want to make sure that I addressed one of the other pre-questions, which was, if you've had progression and they are unable to do a biopsy, how do you know, without being able to test the mets and what, you know, mutations have occurred, how do you know what treatment to go to next? And that was actually my experience for the first 4.5 years of my experience with metastatic breast cancer, because I had bone-only mets. And all of the bone biopsies that we tried failed because there is a process of decalcification when they take cancer out of your bones that oftentimes destroys the ability to see what was there. And so every time I got a bone biopsy, it was like, yep, that was bone. That was all we got out of these biopsies. And so legitimately, what we were doing with all of the medications that I was on until the cancer spread to my liver in January was guessing. The doctors were guessing based on their clinical knowledge, based on the statistics. Yes, it was an educated guess about what we might be able to do, but we were working off of the genomic testing that they had done on my original breast tumor when I was originally diagnosed in 2017. And for 4.5 years, that's all the information that we had. Now, there is also such a thing as a liquid biopsy where they take blood and they do genomic testing on your blood. Now, many of these tests are not even approved by the FDA yet because it is such a growing area of research. But sometimes somatic mutations can show up in the blood. The challenge is that you cannot test every drop of blood in your body. And there's no way to know for sure if a circulating tumor cell is in whatever vials of blood that they pull. And so it's not as reliable as a tissue biopsy. But it can help confirm maybe things you already know about the original tumor, and then the doctors make educated guesses based on their clinical experience. And this is why I love getting second opinions. And I always recommend to people, if you are not fully comfortable with what your doctor is saying, go ask somebody else, because doctors are not God. All the doctors have the same access to the research, but yet they've developed different clinical comfort levels with different types of treatment. And so that doesn't mean anybody is right or wrong. It's just that their experiences have been one way or another. And I think that, getting my thought process always is the more smart people who are thinking about what's good for the cancer in my body, the better. I would like every smart person in the world to be solving the puzzle of the cancer in my body. So I think that's where second opinions can be very helpful, but it is pretty scary when you don't have current information about the metastasis. You don't know for sure if the medication that you're on is right.
Hey,
but let
Abigail.
me tell you, go ahead. Hold on a second. Even when we do have all of the information, we still don't know for sure if the medication is going to actually work. So I've still had progression, even when I had the mutation and the medication was targeting that mutation, still had progression there. So you never know for sure, but having more information is better. Go ahead, Amy, sorry.
So I wanted to just piggyback on what Abigail said about imaging. So this is where imaging comes into place too. And people often ask, why do I get a PET scan? Why does my doctor order a bone scan? It's preference on how they look at stuff, how the type of cancer you have reacts to the different types of imaging. But it also goes, if you have something and they're not committed to saying that this is a progression, like say you go for a scan and something's a little abnormal and they say it may be a little bit bigger. So just wanted to add, if it's a different doctor reading it, no two sets of eyes measure the things the same way. So just remember that. So if you have progression or they're making you wait, they're not trying to torture you. They're trying to make sure if what they see is real. If it's on the scan, if it's not, that's why they often do a short-term interval follow-up, like 3 to 6 months. Or if you had a CAT scan, they'll say, hey, go for an MRI, because those tests become more dedicated as you move through. So just stay on your oncologist or your medical team, just encouraging you again to listen to your body. But if the medical team can't give you a direct diagnosis, that's why. They might be trying to suggest that you have a different test. When your insurance gives you resistance, there are certain codes that your doctor can use. Just ask your doctor to do peer-to-peer. So just wanted to put that out there, because she was talking about if you can't have a biopsy or if you have certain things and you can't have certain medical tests, there are other options.
And they're getting better all the time,
Yeah.
all those tests. There's in fact a brand new type of PET scan that is specific to those of us who are hormone positive. PET scans are not the best for lobular cancers because they don't metabolize the glucose in the same way, but also for those of us who are hormone positive, some of the radioactive elements that they use it just doesn't react the same with our bodies. And so they're getting better and better at some of those things. We just don't all have access to them yet. But thank you, Amy, for that reminder. Amanda, did you want to add something there?
Yes, I think this is all such good information, and scans, giving us the information we need to make informed decisions. And I say us because I do consider myself on my oncologist team, it's my care. And so I've become a very vocal voice in what happens next. But another thing that I can't stress enough is just get second and third and fourth opinions. Like Abigail has mentioned, that's something she's taught me. And I have my local oncologist now who consults with the oncologist who I see at Dana-Farber in Boston. And sometimes you might think, well, I can't travel, I can't, it's too much work. But a lot of oncologists are now able to see, through telehealth or telemedicine. It's always worth an ask. And, the more, I guess the phrase cooks in the kitchen, the better, because somebody's going to see something or know something different than, somebody you've worked with for a while. And I think that could be the difference between a treatment that you have, is the right next treatment, and then something that might not be the right next treatment. And so I take those moments where we have to make decisions, I take them very seriously, and I get the opinion of everybody involved if I can, even to the point of like a radiation oncologist, because progression in bones is very different than having progression in your liver. And so there's just a lot to consider. It's not cut and dry. I know you guys all know this, but second, third opinions, I'm a big fan. Yeah.
I've always wanted to go to the tumor boards when all the doctors are talking about whatever cases. And there is actually on Twitter, they call it Tumor Board Tuesdays, I think, or maybe it's Thursdays, where they actually take a case and it's multiple doctors actually talking about the case. So I encourage all of you to perhaps follow that. I know Janice, you keep talking about Janice. I should have had Janice come talk to us today too, but she's been interacting with the doctors who are talking about it. And I think it's just a great way of seeing how doctors think about things, like watching their brains work on, I don't know if it's a real case or if it's a made up case.
No,
but,
they're real, Abigail, they're real cases. They take
Okay.
your lab work, they take imaging. I've sat on some of the boards. They take your blood work, they take everything that you've had and they present it to a group of people to see if they would weigh in and agree on how to treat, or to see if they can take it, because they have other connections, take it somewhere else to get an opinion outside of the organization and come back and give you more information.
Yeah, I was talking about the one on Twitter. I don't know if it's real cases on Twitter, but
I would bet you it's a real case. Yeah.
It probably is. Peggy was just asking the question about scans. Can scans tell you what the receptor status is and mutations? They can't, right? The scans are just showing you how the body is reacting to whatever tracer or whatever whatever was injected, right, Amy?
Yes. So if you get a PET scan, that's telling you like how it's metabolizing. So then they know how aggressive it might be, or if it's not. For PET CT, for like bone scans and all that, that's still another type of way your body's metabolizing. So it basically is showing how active the cancer is, if it's active or not active. Because if you'll look at your reports, if you've ever had one where you don't have progression, they'll mention that you might have a lesion, but they'll say it's not active. It's like scarred over. So if you watch and you just like get familiar with your reports or whatever, it'll help you understand what they're seeing. But normally a scan is what would help them know that they need to do a biopsy or draw lab work, or that the treatment is not working, what you're on. Or when you start a new treatment, they'll often tell you it takes about 3 months for it to look different on imaging. It doesn't always show immediately. So not to panic if you have changes the first month or two.
Yes. The FES PET scan that that people are talking about in the chat is the one that is designed for people with hormone positive disease, because the estrogen reacts differently with the tracer that they're using. It's a different tracer. So that's the thing that they inject you with. Contrast, is somebody call it contrast. It as your body metabolizes whatever it is that they've injected in you, then it looks different on the picture. Yes, Amy, am I saying that right?
Yeah. Yeah. And then if you ever notice when you have a PET scan, you have to be quiet for like 45 minutes to an hour, hour and a half. It's because if you got up and became active, then all your muscles and stuff would highlight on there because your body's having to use more like sugar and stuff in the system. That's why they have you sit quiet. Somebody just asked about a PET scan and a CT. So when you have a CAT scan, it's timed. And so a lot of times with liver stuff, your liver is very vascular. So when you have a CAT scan, they see the lesions a little better because they're giving you contrast that's going through your bloodstream. And so it's going to those cells. So when they look at the liver, they can differentiate the different tumors. And on the PET scan is if you have something active, they do like a CT and then they mask the PET scan over it. But when they're looking for liver mets and they want to see if they're vascular or not vascular, or if it's like a hemangioma or something else, that's why they do the CT. I think that was the only other question.
All kinds of different things that the different scans can do. And I always think it's so important. I mean, people ask this in all the groups all the time, like, why is one doctor doing PET scans and the other doctor is doing bone scans and CT scans? And a lot of times, unfortunately, that's all about insurance, because a lot of insurance companies don't want to pay for PET scans. Or it could just be that the particular metastases that are in your body, they see better on a bone scan, or they see better on a CT scan. I've also noticed that some of the newer doctors tend to do things a little differently than the doctors who have been around for 20, 30, 40 years. I've noticed that it's different on the East Coast versus the West Coast. So there does seem to be some of that, it's different, but, I've always am a proponent of saying to the doctor, okay, why is this scan the thing that you want? What are you looking for out of this particular scan? And why is that scan important right now? So definitely asking your doctor those things, or you can just call Amy, because Amy can tell you probably exactly what the doctor's looking for.
So Abigail, one thing is when you do a PET scan, it's from your eyes to your thighs. And when you do a CT, you're doing your chest, abdomen, and pelvis, which is your trunk. And then when you do a bone scan, the bone scan covers your entire body from skull to your feet. So for those of us that's had bone mets, that's why they sometimes go to a bone scan. I laugh because in one of our groups, everybody's like, PET scan, PET scan, PET scan. I recently had a PET scan, and on my PET scan, it said that I should be having a bone scan. So I laughed hysterical because it's different ways, but my mets was bones. So like they took the history, the doctor actually read the history, and so they're looking at it. So I'll have a PET scan, but I'll probably have to have a bone scan too, because that's what's recommended. So if your doctor goes to CT and bone scans, it's probably because your insurance pushed it that way, but it's also, that was the gold standard for looking for mets. And so PET scan, even though it's been around for years, it's not made the gold standard for all breast cancer. For other cancers, it is the gold standard. So it's just, like I said, what the preference is of your oncology team.
And great to ask questions along the lines, whatever your doctor is doing or however they're doing that. All right. So yes, Mary, PET scans will often give exact measurements, while as bone scans won't. And that's because of how the tracer, how it shows up. That, and because those of us who have bone mets, they will always show up on a bone scan, because healing bone, necrotic bone, sclerotic, all of those words, it's when the bone is healing, and that will always show up as scarring basically on the bones. And so that's why for the people who have bone only disease, you can't ever get to no evidence of disease, because that scarring on your bones will always be there. And so that's why we say no evidence of active disease, because even though on a bone scan that those places of scarring show up as black on a bone scan, they're not lighting up on the PET scan because they're not metabolically active. They're just scarring there.
But
Did you
also,
have something else, Aim?
Yeah, but also on the PET scan, they do a CAT scan that goes with the PET scan. So it's like some 3D imaging, so they can make measurements. On a bone scan, it's like all these little dots, and it's just like 2-dimensional, not 3-dimensional. So on the bone scan, they can't really measure how big something is. And so if something shows up, you will have to have some other kind of scan for them to make measurements to see how big it is.
Right. And the measurements are important so that they can compare something has
Yep.
grown
Yep.
or decreased, right? I mean,
Yep.
that's why they take those
Yep.
those measurements. All right. So in a moment, I'm going to ask each of our panelists to tell us what word it is that would exemplify our conversations today. But I did just want to throw in there a different perspective about the different types of progression. So for the first 4.5 years of my diagnosis, I had different progressions within my bones. And so that would be a new spot showed up here, a new spot showed up there. Maybe the areas were getting bigger. We could attack it with radiation. And while I did change medications several times, I got years off of each medication. And so then in January of this year, the cancer spread from my bones and went to my liver. I had two progressions in a row. Far different from Amanda, who's had probably like 5 or 6 in a row, but having 2 progressions in a row, 2 bad scans in a row was really psychologically difficult. But for the first 4.5 years of my diagnosis, I was hanging my hat on the bone mets aren't going to kill me, right? I mean, bones can break, but it's not going to kill me. And there are some studies that show that people with bone-only mets have about twice as long of a life expectancy statistically than people with soft tissue mets. Because you can live without a bone, they can literally cut one of your limbs off if you need to. Or like me, I have rods in both of my femurs. So even if my femurs were to fracture at this point, it would be fine because there's a titanium rod there. But once the mets go into your liver, or to your lungs, or to some other body part that's somewhat important for living, it was a huge difference in my mind, because for probably, even though I thought I had been facing the fact that metastatic breast cancer is something that will end my life at some point, having the Met in a body part that I needed, in an organ, that if it failed, then I would die, that was probably almost as difficult, maybe even more difficult than the original diagnosis, because it got really real, really fast. My blood work would never changed. So it wasn't until we did the biopsy, and then my liver was very mad for a while about the biopsy. But it was an entirely different experience. And I think that progression, different from all of the other progressions, finally made me look at what really is going to happen. Not that I wasn't trying to look at it beforehand. Like I said, we've had lots of conversations about end of life things here on this webinar series, as well as just other people that I've talked to. But when the metastasis is in a place that could actually end your life, and some of you had this from the very beginning, but that was a hugely different perspective for me. And it got a lot harder to face what was happening. And so I called my doctor and got on some more antidepressant medication and some more anti-anxiety medication, because there are some things that your coping mechanisms, as robust and as varied as they are, they're just not up to the task. And so I just want to encourage all of you, as you face progression, as you face differences, whether it's a tumor growing, or differences in being able to tolerate medication. These are all really hard things that can remind all of us about the fact that this is not a disease where there is a cure. And that is a very difficult thing to carry. So do not be shy about reaching out for help, whether that's in the MBC community, whether that's a psychiatrist who can help you with medication, whether that's a counselor, whether that's just a mentor. Certainly there are lots of different opportunities within the MBC community to reach out to get that support. But do not feel as though these things are wrong or you're having an extreme reaction. My father is a mental health counselor, and we moderate a support group, and he reminds everybody in the support group regularly, mental health is when your emotional reaction matches what is happening to you. That's what mental health is. And it absolutely matches when you're going through the trauma of a progression, of a diagnosis, scans, of other people having difficulty. It is absolutely healthy to struggle. It is absolutely healthy to have a bad reaction to those things, because none of these things are easy. And none of these things are something that is easy to carry, because it's not that it's just a day. It's not that it's just an event. It is our entire lives. So just wanted to end on that. Laura, can I call on you first to see what word you feel like exemplifies today and our discussion today?
Was that only because I look like I'm about to start crying?
I'm sorry.
I have two words. I was thinking about this earlier. One is love and one is growth. The growth is a little bit humorous because we're talking about progression, so growth and all of that stuff. But like, honestly, though, the growth that we're learning from this conversation, that the growth we have as this community, this growth that we're having to support each other, and that we're creating this space to share our growth, our progression, our everything we're dealing with. Love is because of everything everyone is so willing and transparently sharing today and in all of our groups, and that we could really come together and share the multitude of resources that are available, and that there's a lot of love out there for us. So thank you.
Absolutely. I keep being told by people in other cancer communities that they're jealous of the breast cancer community because of how much support and love for each other that is shown within the community. And I think that's very true of the MBC community specifically. All right, Amy, what word comes to your mind?
So I have two words. So I often share in the breast cancer community, but I don't always share at work because I don't want women to think when they're newly diagnosed that they're going to automatically get diagnosed. So awareness is one. Awareness, Amanda, thanks for saying that you can celebrate, because for me, I feel guilty a lot and don't want to say how many treatments I've had or share because I feel guilty that I haven't had a progression. So thanks for that, because I didn't realize it was something that was beneficial to you. And advocacy. Advocacy is a huge thing for me, and I haven't been able to figure out where my lane is. But every time I share, I kind of learn a little bit more about myself and what I need to share. So for that, Laura, I thank you for this group and this advocate and this place. So thank you.
Thank you, Amy. All right, Claudia, what word comes to your mind?
The word that comes to my mind is human. We are humans because, and we have faults. We have to celebrate as humans, celebrate every day, celebrate successes, our successes, or somebody else's success. We are humans because we are vulnerable, and we don't have it all together every single day of our lives, and we have to accept that. And I think that's it. I'm not gonna start crying, so yes.
Thank you, Claudia. All right, Amanda, over to you. What word comes to your mind?
I could echo all of those words. I'm gonna echo one in particular, and that is advocacy. And I know we use that in terms of being an advocate in the community or with those who might not understand the disease, and that is so important. But in this case, self-advocacy. And I think can't stress enough that you are on your doctor's treatment team. This is, about you. And I've had to learn how to get in there, and I'm my own best advocate. It's going to fall on me. And so I would encourage you guys to do that too, with love and as a human. So
just pull it all together into one. Thank you, Amanda. My word for today is community, because we are definitely stronger together. We can learn from one another, and because we all come from different backgrounds and come to this cancer experience with different perspectives and different ages and different experiences, I think that this community is so important. So thank you all for being here today to hear about the people on the panel their experiences with progression. I hope you will tell us if there is any topic that you think would be beneficial. I think maybe we should just have Amy come back and just talk about different scans. That would be like a whole entire webinar. Thank you all for being here. Laura, did you want to close this out?
No, I just thank you all for your continued support, engagement, ideas, and everything. So, I mean, you guys are the ones that are making it happen. I tell Abigail all the time, if there's interest, we will go out and build it. And that's exactly what we're doing. So thank you.
All right, everyone. Have a
See you all in
wonderful
2
rest
weeks.
of your
Thank you.
Sunday. Bye,
Bye.
everybody.